Hi, and welcome to our webinar on initiating and adjusting insulin therapy for type 2 diabetes. This is Dr. Athena Phyllis Tsimikis, Corporate Vice President of the Scripps-Whittier Diabetes Institute and endocrinologist. Here with me today is Stephanie Decker.
Thank you, Athena. I am an RN, certified diabetes educator and a manager for the Scripps-Whittier Diabetes Professional Education and Training Programs.
Today we're going to be reviewing a number of areas in our discussion for managing basal bolus insulin management. We'll be assessing patient fears and beliefs, basal bolus insulin review, ADA insulin recommendations, case studies. Getting started. When someone starts on insulin therapy, what are some of the things that they're thinking about? It's not always that easy. Attitude, how does the patient feel about insulin? Is there something in their background, family members that have been started on insulin, that may sway their decision on starting insulin? How about skills? Can the patient read numbers? Can the patient see well enough to draw up an insulin dose? Does the patient have sufficient manual dexterity to handle a vial and syringe? And can the patient take glucose readings correctly? All of these may seem simple for a professional, but patients first starting insulin and learning how to manage their blood glucoses, this might be a challenge for them. Lifestyle. Does the patient understand appropriate nutrition? Does he know how to read labels? Does the patient exercise, which may influence his blood sugar readings? And does the patient have any family support to help him out with this concept of insulin management? A recent study was done and looked at insulin-naive patients and why they might be averse to the possibility of insulin therapy. In the DAWN study, issues such as a perceived loss of control over one's life, poor self-efficacy about insulin therapy, and personal failure were all areas that played a role in whether they might or might not be able to handle insulin therapy. Perceived disease severity. Sometimes patients feel that once they start insulin, this actually means that their condition has worsened to a point where it's non-reversible. Injection-related anxiety. Approximately 50% of patients are afraid of an injection. And perceived lack of positive gain, that they may not believe that insulin will actually help them improve their health, their energy, and reduce complications. When we look at the current practice paradigms, how do we actually start people on therapy for their diabetes that might be out of control? This is the current practice paradigm. We almost always start people on diet and exercise first. If their blood sugars aren't under control after a month or two, we'll usually add a single agent of monotherapy. And from there, step it up, combinations of oral agents, and then finally, insulin. There are problems with this, though. Glycemic targets might not be met. Monotherapy in many studies has been shown to not be effective for the long term. Treatment failure fails to address all the impairments. And the stepwise approach makes patients feel that once they end up on insulin as if they have failed, rather than taking into consideration that any or all of these agents may be needed to fully control someone's diabetes. Glucose toxicity can interfere with treatment response, and financial considerations for each patient needs to be taken into account. It is possible that some of the agents, especially the newer agents, may be more expensive than what they are able to provide, and that insulin therapy may be able to handle and manage their disease in a much more efficacious manner. This was one very interesting study done from Kaiser Permanente group, and what it showed was how long does it actually take physicians to escalate treatment? Is there some inertia involved in moving therapy along? So if you take a look at the top of this slide, diet and exercise for these patients wasn't enough. Their average A1C at that point was 8.6%, and the number of months that their A1C was above 8% was 8.7 months. Taking this further, when sulfonylureas alone were used, the average A1C was 8.8% for 20.5 months before any therapy was escalated. On metformin alone, similar findings, an A1C of 9.1% with 14 and a half months before any therapy was changed. And even when they were on combination metformin and sulfonylurea, the average A1C was 9.6% for 25.6 months before any changes were made. All this tells us that we're still probably not advancing therapy in type 2 diabetes at a rate that would be optimal for patients that allows them to reduce their complications and best manage their disease. This slide shows an algorithm first presented by David Nathan in Diabetes Care that shows us a stepwise approach to instituting therapy for type 2 diabetes. As certainly recommended by a number of bodies, lifestyle recommendations are always first, along with metformin, which is inexpensive, has less weight gain and many times weight loss, as well as very effective glucose management. Step 2 offers now a number of therapeutic options, and everything from adding basal insulin, sulfonylureas, TZDs such as pioglitazone, or GLP-1 agonists are now in this step 2 algorithm. In addition, any other one of the combinations can be added to the first agent in order to make this even more effective. And finally, step 3 would be adding intensive insulin in order to optimally manage the patient's disease. This just gives a little more detail. At what point in time would you actually want to incrementally increase and make these additions? If you use an A1C that's greater than 7% as your target for initiating therapy, and then use the target of 7% or less as your trigger point for making the changes, usually at a rate of every 2 to 3 months following this value, you can then see how you would rapidly achieve optimal glucose control. Okay, I'm going to turn it over to Stephanie now to get us started on basal insulin.
Let's look at some reasons when you're looking at your patient to start initiating basal insulin. One of the primary goals to look at is the A1C is not less than 7. Other things to look at, the patient is not prepared or able to take multiple daily injections at this time. So what this requires is a discussion and a plan with the patient ahead of time to determine, is this somebody who may need basal bolus insulin, but they're only willing to take 1 injection at this point? When you're looking at the fasting glucose, is that glucose consistently above a healthy goal? When we give basal insulin, especially when we give that basal insulin at bedtime, it will help decrease that fasting glucose, and that's one of the benefits of starting a basal insulin as well. The person is willing to monitor their fasting glucose. Again, typically we're giving that basal at bedtime, and knowing what that fasting glucose is, the patient's able to titrate at home, or when they call you, you are able to titrate their insulin based on the fasting glucose results. This is also the possible beginning of starting basal bolus therapy. Basal insulin can be given once or twice a day. Most likely, the patient is started in a once daily regimen. With type 2 diabetes, we can use a basal insulin in combination with the oral diabetes medications, and we have several basal insulins to talk about: glargine, detamir, and MPH insulin. Let's look at these a little more closely. When we look at glargine and detamir, as you can see, these 2 insulins physiologically mimic, more like our own pancreas would, produce basal insulin. MPH has a much shorter duration and also has a peak. So when we look at physiological response, glargine and detamir fit that bill much better. A couple of considerations with glargine and detamir: both of those insulins cannot be mixed with any other insulin. So if a patient does require to give simultaneous bolus insulin, the patient needs to be instructed to give 2 separate injections, 2 separate syringes. Another important teaching point with basal insulin, many patients feel once they start insulin that that's going to affect any food that they eat. An important piece with glargine and detamere, they work too slowly to affect any food, so patients need to be reminded to eat healthfully. When it comes to cost, you can see MPH is less expensive than glargine and detamere. However, I just want to remind you that both of these insulins do have patient assistance programs, so patients that meet certain financial criteria can actually get those insulins at a 3-month supply sent to your office. This gives us a visual to contrast MPH and detamere and glargine. And again, you can see the duration of both of those insulins. Detamere and both glargine is up to 24 hours. MPH really lasts about 10 to 14 hours. And anytime you have a peaking insulin, such as MPH, you run the risk of hypoglycemia. These insulins come in insulin pens, which are very easy for the patient to use. So especially if their insurance pays for something like this, I would encourage you to consider starting the patient out on an insulin pen. I'd like to ask you for a moment to reflect on a couple of these words that you see before you. Novolin, Humulin, analog. What does Novolin and Humulin mean to you? Many people think this is actually one type of insulin, when in fact, these are brand names for 3 different types of insulin. Novolin is Novo Nordisk's version of MPH, regular, or 70/30 insulin. Humulin is Lilly, the other pharmaceutical company that makes insulin, their version of MPH, regular, or 70/30. So if a patient says, I take Humulin 10 units BID or Novolin 15 units BID, the patient needs to be questioned further to see if it's MPH, regular, or 70/30. Analog refers to any of the newer insulins that we now have out on the market, such as Levemir, Glargine, Aspart, Lispro, Glulisine. Let's take a look at James. James is a 55-year-old gentleman with type 2 diabetes for 12 years. He's on glipizide 10 milligrams BID, metformin 1,000 milligrams BID. His A1C currently is 9.7. For the last couple of months, he's been running about 9.5. His weight is 225 pounds. He's 5'9". He's an executive at SDG&E. He smokes. He eats out in restaurants about 4 nights a week and had cardiac stents several months ago. One of the things to consider when you're looking at James' history is the duration of his diabetes. We know diabetes is a progressive disease in that the longer the person has diabetes, the less insulin the pancreas is making. So this is something that you commonly see, a patient with a history of diabetes for several years, still on oral agents, and the A1C is still not in control. When we look at James' logbook, what does that A1C tell us first of all? His A1C was 9.7. What we know by Monnier and some of his colleagues who looked at what does the A1C contribute to when it comes to what part of the day, I'm going to have to edit that part because I'm going to start over because I got goofy on that. So let's look at James' glucose logbook. What does the A1C tell you? That his A1C was 9.7. The higher an A1C, especially when you look at 9 and above, you're looking at the fasting glucose contributing almost 70% to that A1C level. When we look at his logbook, you can see his fasting glucoses are elevated. Can you increase his orals? James was on 10 of glipizide and 1,000 milligrams of metformin. 10 of glipizide BID, I should say. Yes, you could increase the orals a little bit, but I would ask you to think, is that really going to be effective for him? He's had diabetes for 12 years. His A1C is not at goal. would increasing those orals really make a difference? And the answer would be no. So how do we start a basal insulin? Let's look at adding a single basal dose to James' regimen. You have several options. When you look at the packet insert, you'll see a description to start 10 units at bedtime for a patient. That is one way to start. Another way that may be a little more effective, because you're looking at the weight base, is to start somebody based on their weight. What you want to do is put their weight in pounds, put that into kilograms, and multiply that by 0.2 units. That will give you the total amount of basal insulin to start somebody on based on their weight. When we look at James, his weight is 102 kilograms. When we multiply that by 0.2, that gives James a starting dose of 20 units of basal.
Steph, can I just step in a minute and point out that although using the 10-unit dose is very simple and many physicians would like to just start with 10 units, using this calculation gives you the option to actually start at a higher dose and feel more comfortable about that dosing. Either way can work very well, either 10 units and then make sure that you step it up appropriately to meet your goal, or do the calculation and be comfortable in using a very conservative starting dose of 20 units and still ensuring that the patient is safely being started on his basal dose.
Let's talk about what insulin might be appropriate depending on insurance. Again, even if the patient is uninsured, if they are following with you consistently, you could apply for the patient assistance program and be able to get Glargine or Levemir sent to your office. If the patient is uninsured and not following with you consistently, or there's some barrier to you getting the insulin, Detamir or Glargine to the office, then your only option really is going to be MPH insulin. So when would you use a mixed dose insulin? This is something, again, to consider before even starting the insulin. If you feel that patient really needs basal bolus insulin, but they're not willing to take more than one injection at a time, this would also be another time to consider starting a mixed dose at dinner, knowing that as soon as that patient becomes more comfortable with giving a single dose injection, that you're going to move them to also starting a daytime injection. The other thing that you want to look at is establishing an individualized fasting glucose goal for that particular patient. If somebody's elderly or they're labile, or you have some concerns about hypoglycemia, you may want to start that fasting initial goal at 150. Or if they're able to, you may want to start to say 120 or 110. Eventually, if it's appropriate for the patient, you may want to have a fasting goal of 100. So again, let's look a moment. This reviews with you the algorithm for starting a basal insulin, your options, your true basal, which would be the Detamir or the Glargine. The MPH does have that peak and does not last 24 hours, but that could be another option. Or looking at your pre-mixed insulins, knowing that that patient really needs basal bolus and they need to be giving an insulin BID at some point soon. So what time to dose? Typically, Detamir or Glargine, you're looking at giving at bedtime. One time to consider, or one thing to consider with giving it in the morning, is if a patient has had past experience with hypoglycemia in the middle of the night. So those patients, you may want to consider giving Detamir or Glargine in the morning. Also, anybody who's a shift worker could certainly give those two insulins in the morning as well. One of the important teaching points with those insulins, though, whether it's given in the morning or given at bedtime, is that the patient really try to take that insulin at the same time every day because of the 24-hour lasting period. MPH typically would like to give that insulin between 9 p.m. and 11 p.m. Part of the reason, there's two reasons for that. One is a safety issue. If you give MPH at dinner time, it's going to start to peak in the middle of the night, and you're looking at a 2 or 3 a.m. potential for that glucose going too low. If you give the MPH and move it to bedtime, you decrease that risk of nocturnal hypoglycemia, And the insulin is peaking more towards the early morning when the person's hormones, natural hormones are being secreted that elevate the glucose anyway. So it kind of all works together. If you did determine a premixed insulin would benefit the patient, not only do they have a high fasting, but their bedtime sugars are high, and they are a candidate to go on to basal bolus, you would want to give that premixed insulin at dinner time. Other considerations when you start a basal insulin. You may need to decrease or discontinue any DPP-4 inhibitors. There is a higher risk of hypoglycemia when you initiate therapy, insulin therapy with these medications. Any of the GLP-1 agonists have not been FDA approved with insulin or studied at this point. Rosiglitazone in the package insert actually states if a person has a cardiac history, it recommends not using rosiglitazone with insulin. It may increase the possibility of the person having a cardiac event. Continue the sulfonylurea and any other orals, but do decrease or discontinue those sulfonylureas, especially as that person's fasting glucose gets closer to goal. So from a safety perspective, you may want to have the fasting goal at 150 and have the patient call you or come into the office once that fasting gets down to 150 with the basal insulin, and then start to discontinue or greatly decrease the sulfonylurea. Here is a recommendation by the American Diabetes Association for how to adjust basal insulin. If the patient is able to do this, this is something that can be done at home, and then you could have weekly phone contact or biweekly phone contact depending on how the person's doing. The person can be instructed to check their fasting glucose daily and increase their basal insulin dose by 2 units every 3 days until the fasting glucose reaches that target range. Another method is another recommendation is if the fasting glucose is greater than 180 to actually increase the basal dose by 4 units every 3 days.
Steph, I also want to add here that this is where using your certified diabetes educators or your diabetes education program may be of value. Our diabetes educators are very well informed in helping patients and guiding patients through these adjustments, and following a protocol or an algorithm. They can help the patients do this as well, together with the primary care physician.
So some of the benefits to self-adjusting, the patient actively feels like they're involved in their diabetes care, and this is really what diabetes management is all about. The patient also has less fear of hypoglycemia because they're only increasing their insulin every couple of days by a couple of units. One of the really positive and strong benefits of this is that a patient really starts to see gradual changes in their blood sugar, and they feel like they're seeing some active changes and progressing towards a healthy glucose. One of the things that is important when you're starting to prescribe insulin therapy is that you also, on the prescription, write the insulin type, the dose. Make sure you state the dosage frequency, whether it's by a vial or, again, an insulin pre-filled pen. If you do order a pre-filled pen, you also need to prescribe pen needles. Does that patient have a meter? If not, they certainly need to be monitoring their glucoses, and in that case, you would also need to write for lancets and strips. A point I want to make with the insulin syringe, if you are going to prescribe vial and syringe, it's very important to write the size of the syringe on that prescription. There are actually 3 different insulin syringe sizes. The 1/3 cc, which delivers 30 units of insulin, the 1/2 cc, which delivers 50 units, and the 1 cc that delivers 100. At adolescents or children or very labile adults, the Novo Junior pen actually delivers 1/2 cc increments. Now, one of the important things with prescribing the correct size of the syringe, if you do not write any size on that prescription, 99% of the time, all patients will be given a 1 cc syringe. The problem with this is the 1 cc syringe, each black line on that syringe is equal to 2 units of insulin versus the 1/3 and the half cc syringe where each black line is equal to 1 unit. So there have been instances where patients have made mistakes in their measuring, not realizing that that 1 cc, each line counts as 2 units. So please do write. Most patients would benefit from the half cc, some for the 1/3 cc if you know they're going to be on very small doses. But there are not that many patients starting off on insulin that actually need the 1 cc syringe. For needle size, there's 2 sizes. There's a short and a regular length. And most people with type 2 would benefit from the regular length because of the increased BMI. It's very important when you start insulin therapy to always have hypoglycemia teaching as well. This is a handout that we have in some of our patient education material that goes over the causes, signs and symptoms, and treatment. And less than 70 is hypoglycemia. Here are some examples of how patients should treat if the glucose is between 50 and 69. Each of these sources that you see on the slide are 1 serving basically to treat the hypoglycemia. If somebody has a glucose less than 50, they actually need to double the source of their carbohydrate. So it's a double treatment if the glucose is less than 50.
Steph, again, many times in physicians' offices, they don't have enough time to really train patients in the proper way of treating hypoglycemia. So using your educators to help you do this would again be an important way to utilize those teams.
So let's take a look at James with his 3-month follow-up visit. We started James with 20 units of glargine. At home, he was self-adjusting his basal insulin, and when he comes in for his 3-month visit, he's up to 65 units of glargine at bedtime. So one of the things to look at is how many units per kilogram is James taking with his basal insulin now. So if we take his number of units divided by his kilograms, we can see now that he's taking 0.63 units per kilogram. His A1C was 9.7. His fasting glucoses were in the 200s. Now at this 3-month visit, his A1C is down to 8.1, and his glucoses are into the 100s.
So this is an interesting calculation, and although it's never fun to have to do too much math, the point of looking at how many units per kilogram James is on is that for basal insulin in particular, once you start getting to 0.6, 0.7 units per kilogram, that's the time when you have to start thinking, does this person now need some bolus to take care of his glucose issues? His A1C is still not at target, and using increasing doses of basal will not necessarily improve his overall picture. So it's the one reason we do the math. Keep in mind that 0.6, 0.7 units per kilo is the point at which you want to stop increasing your basal and start thinking about adding bolus. Back to you, Steph.
So when we look at James' glucose logbook, as Dr. Tamikas just said, that A1C tells us we're still not at goal. And when that A1C is now less than 9 and you're looking at an A1C between above 7 and into the low 8s, you're really looking at a postprandial glucose issue. So when we look at his glucose pattern, we see that the lunch glucose is elevated, the dinner glucose is elevated, the bedtime glucose is elevated. When you see that that meal-to-meal glucose is elevated, it's telling you that that person also has a high postprandial after they're eating and the glucose is not coming down into a healthy range. For instance, let's just look at the Sunday breakfast. His breakfast pre-meal glucose was 101. If his lunch meal was 182 pre-meal, you know that his sugar, his glucose elevated probably into the high 200s, even low 300s, but within 4 hours came down to 182. So that also, even if you don't have that A1C available right away, is telling you that those postprandials are an issue. When we look at the algorithm related to advancing from basal to adding bolus insulin, you're looking at doing that when the fasting glucose is acceptable, but the A1C is still not less than 7, or the rest of the pre-meal glucoses throughout the day are too high. And as Dr. Tamika mentioned earlier, when you do the math, if that basal insulin is starting to reach that 0.5, 0.6, or 0.7 units per kilogram, at this point you need to start to consider adding bolus insulin. So when we look at our options for bolus insulin, on the right side of your screen you see glulisine, lispro, and aspart. All of those insulins are considered rapid-acting insulin. Although they have different names, they really all basically work the same. The onset of each of those insulins really mimics more completely what your pancreas would be doing during a mealtime. They secrete or they inject the insulin, and it gets absorbed into the body quickly, and it really only lasts about 3 or 4 hours, which is physiologically what your body would be doing with a meal. When we compare glulisine, lispro, and aspart to regular insulin, which is considered a short-acting insulin, you can see the onset for regular insulin is about 30 minutes versus the 5 minutes or so that the rapid-acting insulins take to start to get into the system. One of the problems with regular insulin is it doesn't start to peak for 2 to 4 hours. When we look at the absorption of carbohydrates in the body, the carbohydrates start to absorb in about 60 to 90 minutes. So again, our rapid-acting insulins are going to match the peak of the food that somebody's eating much more effectively than using regular insulin. The other concern with regular insulin when it comes to meal times is that regular insulin lasts for many people 6 to 8 hours. That increases the risk of a person actually having hypoglycemia post-meal versus those rapid-acting insulins that really work the 3 to 4 hours and certainly less than 5 hours, which mimics normal physiology. Any of the rapid insulins can again be ordered and filled out if you fill out the patient assistance programs for any of your patients who do not have insurance. It's an option to get those insulins to your office as well. If for some reason the patient cannot apply for those insulins to your office, you would have to use regular insulin, but again, it's good teaching on that the patient needs to take the insulin 30 minutes before the meal, and again, being careful with that hypoglycemia 6 hours later down the road. This just gives you a visual of the contrasting the rapid-acting insulins with regular, and you can see again how quickly the rapid-acting insulins take off and peak into the system, and but they don't last as long versus that regular insulin that takes longer to peak and then lasts too long. So what are our bolus options? When we look at the American Diabetes Association's recommendations, the recommendation is to add 4 units of rapid-acting insulin to the largest meal of the day. Then you want to assess the glucose control and add a rapid-acting insulin to the next largest meal once the largest meal is controlled. So it's a step process where you get one meal, address one meal at a time. And for some patients with type 2 diabetes, they may only need 2 injections a day versus having 3 injections a day. So keep that in mind as well, to really tailor the person's insulin need based on what their glucose results are. Some considerations when you are adding a bolus insulin. Sulfonylurea at this point more than likely should be discontinued, especially if you've added more than 1 bolus insulin to a meal. Once you start to add basal bolus insulin to a patient's regimen, physiologically, the sulfonylurea probably isn't doing a lot because they're not making enough insulin, and it just does increase the risk of hypoglycemia, and it's an extra added financial cost. Again, GLP-1 agonists are not recommended with insulin at this time, And there is a precaution with the DPP-4 inhibitors because of hypoglycemia. Currently, sitagliptin is the only DPP-4 inhibitor that is actually approved with insulin. We talked about the rosiglitazone and the prescription precautions related to that. Metformin is actually a medication that you want to continue if there's no contraindications. Because of the effect on insulin resistance, the patient may actually require 30% less insulin, which helps as well. If a person is going to be starting bolus insulin at all meals right off the get-go, one of the safety considerations is to subtract 0.1 units per kilogram of basal insulin so that you decrease that risk of hypoglycemia. So how do we evaluate bolus insulin? Initially, you could have the patient do a pre-meal and a 2-hour post-meal glucose check on that meal that you were starting the 4 units. The goal is to be no higher than 50 points from what the pre-meal glucose was. The patient, again, if they are able to, can self-titrate 1 or 2 units every 3 days looking at that one meal until the glucose is no higher than 50 points from the pre-meal.
Okay, in certain situations, you may need to start a daily insulin dose for the entire basal and bolus needs of a patient. This would not happen very often, especially in the outpatient environment. But if someone comes in very out of control and in need of rapidly getting them into control, these are the calculations that you could then use in order to calculate the full dose. So you would start with calculations of 0.5 to 0.7 units per kilogram. From that, once you have the total, half of that, 50%, is given as the basal dose. It can be given once a day, and then the remaining half is split into 3 equal amounts and given pre-meal as the bolus. This is just an example of how we would do that calculation. If the patient is 150 pounds, you would divide that by 2.2 to convert to kilograms. He is at 68 kilograms. You then multiply that with, if you wanted the more conservative starting dose of 0.5, so that a total daily dose of 34 units is calculated. You then take half of that, 17 units, which is now their basal dose, and give that to them once a day. The bolus, you take the 17 and divide that by 3. Rounding to 6 is fine, and you give 6 units of bolus before each meal. Obviously, it would be important to check blood sugars on a very regular basis with this type of situation to ensure that the patient does not become hypoglycemic at any time period. It is likely, since this is a conservative dosing, that they would need higher doses than this, and then looking at either their fastings or their postprandials or pre-meals, you could adjust either their basal or their bolus as needed. If you want to look at which insulins to adjust, this table lets you know. Looking at their fastings, you might want to adjust their evening dose of basal, whether it's NPH or one of the basal analogs. If their levels are elevated before lunch, then it's their morning bolus. Before dinner, it's their lunch bolus, or potentially their basal, either the AM NPH or the HS basal. If you are checking 2 hours after a meal and notice that their blood sugars are rising either 50 milligrams per deciliter above their pre-meal dose or are consistently above 180 milligrams per deciliter, then the advice to the patient would be that they may need to increase their bolus or reduce their carbohydrate intake. This can be used as a nice behavioral modification change for the patient so that they can recognize that maybe the carbohydrates in their meals should be reduced. Before bedtime elevations would indicate that a dinner bolus is not accurate or potentially that basal doses need to be adjusted. And in the evening, we do have, in the middle of the night, we do have patients on occasion check at 2 or 3 a.m. to ensure that they're not getting hypoglycemic and to recognize if we need to make adjustments on any evening insulin they're taking or adjustments on their basal that may be playing a role in overnight hypoglycemia. This last slide shows a real-world approach to insulin therapy in primary care and is taken from Practice Clinical Diabetes and from 2005, and really gives you a very practical approach. Patients, initially when they're seen and have insulin added, do need to be seen face-to-face. But with proper education from your diabetes education team and with instructions from the physician, many times blood sugars can be either phoned, faxed, or emailed in, and dosage adjustments made in that manner. Patients, when instructed well, are able to do self-adjustment, and many studies show that patients using self-adjustment can reach target just as well as when coming in face-to-face and having physicians or nurses adjust this by protocol. So this may be the wave of the future for adjusting patients on insulin. We hope that you've been interested and learned from this module, starting whether it's basal bolus, and taking these recommendations to your patients to most effectively manage their overall diabetes care. Thanks so much for joining us.
Thank you.